Yeah. Child Health and Adolescent Health, Ministry of Health and Family Welfare. No problem. Good morning and welcome to this session on strategies for the integrated delivery of adolescent health interventions. We have this session divided into two parts. The first 45 minutes will be devoted to learning from some experiences in countries in bringing intersectoral collaboration into place. And then the second 45 minutes will be devoted to looking ahead and say, what will it take to do this in the programs as we move ahead? To chair this session, I'm very pleased to invite Dr. Ajay Khera, Deputy Commissioner, Child Health and Adolescent Health in the Ministry of Health and Family Welfare, Government of India. Can you join me in giving him a big hand? We also have Dr. Anju Malhotra, Gender Advisor for UNICEF, currently in UNICEF headquarters in New York, who's leading, among many other things, with UNFPA, a global program to accelerate action to end child marriage. So really pleased to have both these people here. And we are going to begin with very quick statements from both of them on what is when they hear the term intersectoral collaboration, what's the one message that comes to their mind?
Yeah. Very good morning and welcome to this very important, critical session on intersectoral convergence. And I think we have been talking about this area. And I also remember right in the inaugural, when the Secretary Health was talking, she also emphasized on this issue of intersectoral convergence. Now, to my understanding, the message is that because if we really want to improve health of adolescents, we have to reach to each and every adolescent. Now, in order to reach to each and every adolescent, we need to use variety of platforms, instead of creating the vertical platforms. And I think these platforms are already available, whether they are in schools, whether they are in the community. So I think intersectoral convergence can really help in taking the agenda of adolescent health forward. The only thing is how to bring all those kind of sectors together so that we can move in a very unified direction. And I think we'll hear more from the panelists in terms of how and why. Thank you.
Thank you.
Thanks, Chandra. Thanks, everybody, for having me. I think it's a wonderful thing that we're having a conversation on what does intersectoral mean and how to do it well. Many of us are wedded to very lofty ideas of intersectoral convergence that we've been trying to do for 20, 30 years. And I think the question today should be, what does it mean to actually carry it out? And how do we not overwhelm ourselves with intersectoral convergence? Or how do we not make it token by inviting everybody from various sectors to a meeting and then everybody goes home and does their same old thing? Or how do we not make the agenda so unimplementable because every sector has to play a role that we ask sectors to doing things that they don't know how to do? So I think my question for all of us would be, can we shed some of our more cherished notions of intersectoral convergence and really be innovative in our thinking of what and how to do it meaningfully? Because of course, there's no question you cannot have adolescent health without other sectors playing a critical role in it.
Thank you. Thank you. So we're going to talk about different government sectors working together. We're going to talk about civil society bodies, non-government organizations, private sector working together. But I'd just like to step back a little and talk about a 9-year-old girl or boy who needs to cross the road every day to go to school. What does he or she need? Knowledge and skills about how to cross the road, where to cross the road, where not to cross the road, when to cross the road, what are the danger signs to look for. Knowledge and skills because he and she are developing and need to be taught about how to engage with the other world. We need a pedestrian crossing, lights that work, drivers who respect the rules or are punished if they don't respect the rules. And if this child is, or young adolescent is struck by a vehicle, he or she will need health services, counseling services. So clearly, even in this little analogy, this little example, there's a role of the education, there's a role of making the road safe, and there's a role of people to play in healthcare if necessary. Clearly, when none of this exists, the family has to step in and do the best it can, but ideally we want different sectors to make these complementary contributions. So what we're going to have in this session, the first part, is some quick examples from sexual and reproductive health and from nutrition, so that we can get experiences and then reflect on them as we move forward. Sexual and reproductive health, as well as other areas of adolescent health, looking at nutrition. So let's begin with Susan Igras. Susan Igras is with the Institute for Reproductive Health, Georgetown University. She's going to speak to the experiences in bringing together intersectoral collaboration in the context of the GREAT project in Uganda. For all the presenters, we've told them to stick to a 7.5-minute limit and to answer 5 questions. Why did they believe intersectoral collaboration was important? How did they bring this, make it happen? How did they track it? What do they see as the benefits of this? And what are some lessons they've learned from this? Over to you, Susan. Can we have the first set of slides, please? Not this one. Susan Igras. Yes, please. Go ahead.
Is the timer on? Hello, everybody. Really happy to be here. I'm going to be using some work that was done in Uganda, a couple pieces of work that was done in Uganda to examine where intersectoral convergence was working, how well it was working. And there's actually 2 studies I'm drawing from. One was a scoping study that was done in 2015 looking at policy and program, environment and gaps for very young adolescents program, and then some and that's sort of more of a central level look at the convergence, and then go down to the district level with the great intervention that Chandra was talking about. Neither of these studies was actually looking at convergence per se, but they brought it into their analysis, so I'm pulling from that. And trying to answer 2 questions. One, how is convergence on adolescent sexual and reproductive health working in Uganda? Looking at performance, system performance, and integration impact, trying to anyhow. And can non-governmental actors reinforce and benefit from convergence? So when we started the scoping study, we were looking at adolescent health, and because HIV had been already moved into adolescent health within the ministry, they're kind of put together. But it was clear the ministry was the leader, but you can see there's actually 5 other ministries that were involved in different parts of it. Ministry of Education was really big, but social protection and some of the other places had adolescent health in their policy documents. And so there were structures in place also to facilitate this convergent action. So, and this is as of 2015. Now, the Ministry of Health had steering committees at national level, technical committees, very well-defined members in those committees. And the Ministry of Education, as we were there late 2015, had just established an interministerial commission on sexuality education to try and bring the 2 more together. And at district level too, there were planning committees and district subcommittee on adolescent health, at least in northern Uganda where the GREAT project was working. You can see the range of activities that youth health and well-being encompasses there. So looking at process, what made it work in culling through the documents, part of its historical stability. Decentralization had already happened over some decades, and so systems were already in place to support decentralized decision-making and budgeting. But also stable policy was there. The adolescent health policy had been validated in 2004. Leadership was recognized by all the different stakeholders that we interviewed, regardless of sector, as MOH taking that role. And there were these established operational processes that I mentioned in terms of structures and meetings. We also looked at policy content, and it was very robust policy in terms of positive youth perspective, except there wasn't much gender. So where wasn't it working well when we did our stakeholder interviews? It was really absent in protection policies, which is more GBV oriented. There are policy bottlenecks within the Ministry of Education that was influencing that MOH-MOE relationship convergently. The school health policy remains in draft, even though it was drafted at the same time as the adolescent health policy. More need for resources, lack of data, ambiguity of that interface between systems, healthcare systems or ministry systems in the community. Lack of data is important in the sense that nothing was being disaggregated, so it was really hard to look at who was being reached. Different indicators by each ministry and no core indicators compiled across ministry. Nothing that unusual, I don't think. So let's now move down to the district level. And using convergent structures, the GREAT project was a gender transformative ASRH project that was working across sectors by definition of the breadth of what it was trying to accomplish. Scaling to new districts, which meant that in each district there were new departmental actors, new user organizations. So it was a nice case example of how well convergence was working at that level. And some of the things that the project put in place were they became part of the coordination structure within the government, which also included 3-line ministries, and established at higher level, central level, a technical advisory group. So was it working? How was it working at district level then? Some of the enabling factors in talking with people is the government of Uganda appropriation approaches. It was also good timing post-conflict. The government was looking for gender, youth positive activities to rebuild social cohesion, and GREAT offered that. This whole mandating of the NGOs into planning processes at district level, and sort of an intangible partnership approach where the projects and the government structures were really working together and helping each other when they needed it. And then the project itself, I talked about, had these conscious efforts to integrate across ministries because they were thinking of scaling up from the beginning and these advisory group. So where did it not work so well? There were some gaps in the system. So unclear authority levels and or disconnects between regions and districts, between the community development officers, which are really the big motor, the driver of programs, and the MOE, MOH. And it slowed down decision-making and hence some of the project processes. And what did it, so the question is, moving from the processes, looking at performance and impact. And one of the stakeholders was talking about the ARS field being crowded in Uganda, and it's true. And so coherency was being brought through this convergent structure. It was being valued as something useful, so people were more bought into it. They seemed overall good in terms of the structures and processes, and a need just to improve with M&E for accountability reasons. But what did it bring, from GREAT's perspective, who was trying to add new elements into the government programming? It helped to integrate sensitive themes, this convergence approach, by using a mix of different ministry and NGO actors. And I think one of the most interesting things is, as the project was ending, because it ended in March, one district is already planning to use a more concerted convergence approach to tackle other issues, which is a pretty strong indicator. But it's a cautionary tale without a counterfactual. You know, we know ultimately convergence is supposed to help impact and create equitable quality services, and we don't really know. We don't have that counterfactual to know if it wasn't there, what would happen. And when you looked across at services availability, there were a lot of gaps, more gendered policy, need for more accountability. And this whole role of NGO and civil society actors who could benefit and add to convergence, I think, is an important one that can be played. That's it. Thank you.
Thank you very much. We're not going to leave discussion to the end. We want some quick comments after each. So I'm going to ask one of the chairs, whoever, Anju or Ajay, to say, what's your one takeaway message from this presentation? One question you're left with. Please. The mic is, you can come on.
I think, the takeaway message to my mind is, in terms of convergence, you have built some systems of, so-called the monitoring, I think. Because somehow, we talk about convergence in a very theoretical sense. If we put some systems in place in terms of its monitoring, I think you made a mention about it. That's very impressive.
Thank you very much, Ajay. Sabine, what's your one takeaway from this and one question you're left with? Quickly, let's move. We really have to use this 45 minutes to the full.
What I took away from this is a great start to recognize what system you're working in, and you've done this fantastically well. I think it's also really, really important to highlight and examine the barriers to it. And my one question is, how do you try and overcome the barriers? And perhaps also important, leadership. Leadership is really, really important, I think, which you've recognized and highlighted.
Thank you. Please, a quick
No,
response.
I agree on all of these comments. I think they're really critical things. And when you look at the sort of integration literature, it's a crying need in a lot of different sectors outside of Ugandan countries.
Thank you. Can we give Susan a big hand? The next presenter is Priyanka Srinath from Mamta. She's part of the great Mamta team which helped put together this conference. And she's going to be talking to how they brought about intersectoral coordination in 2 district-level projects to prevent child marriage in one district in Bihar, one district in Rajasthan. Over to you, 7.5 minutes.
Thank you. I'm nervous with all this time tracking. Good morning, everyone. I'm going to present one of the intervention by Mamta, and this was to facilitate sectoral convergence to address child marriage. And this was done during 2012 and 2015 with the support of the Ford Foundation. And we are really lucky to have the moderator for today's session, Dr. Chandra, who has evaluated this project. So the questions can be actually, addressed to him, so I can be spared from that. So we chose the 2 districts. These were very, the high child marriage prevalent districts. One was Jamui in Bihar, and another one was Savai Madhopur in Rajasthan. The 2 states had a prevalence much higher than the national average that time. And in India, almost half of women were getting married below the age of 18. So I don't have to elaborate on the need, because all those who have worked on adolescent health and especially child marriage knows the complexity around child marriage. And that was the period when the governments were also talking about how have we performed on MDGs, and child marriage was emerging as the major culprit for all those, the targets we had not been able to achieve. So it was critical to reduce the incidences of child marriage and adolescent pregnancy to achieve the larger goal of securing adolescent health, education, and reducing maternal mortality and, of course, violence. There was a law on child marriage which was introduced in 2006, and it was a little more comprehensive in comparison to what we had in 1929. And the law actually had the provision of a child marriage prohibition officer at the district level. And the district magistrate was supposed to be the ultimate district, the child marriage prohibition officer, especially in the cases of child marriage. That was the time when Ministry of Women and Child Development, sorry, I'll have to talk a little bit about the structures for the benefit of the participants who are not from India. The Ministry of Women and Child Development is the nodal ministry for the child marriage, and that was the time when ministry realized that we need to have a national strategy and a plan of action to address child marriage. The idea was that maybe, such a plan can actually help necessitate the investments and commitments from different sectors and across different levels. The core committee which was working, and some of the members are also present here, was working on the National Plan of Action. We tried to look into various definitions of sectoral convergence, how it can happen, and what should it look like. We also tried to look into few conversion, definitions. Some were at the top level, strategic and coordinated policy decisions, and some were very simple, talking about the effective service delivery at the ground level. We had our own concept, which was built on the assumption, I should rather say, believe that district level convergence works effectively through the development of a convergent action plan between various departments at the district level. So there is a need to have a district action plan that we saw in Susan's presentation also. And the leadership of the district magistrate being the ultimate child marriage prohibition officer was very important. Hence, we designed this intervention to test the feasibility of departmental convergence to address child marriage at district level. The broad objectives were to, enhance the knowledge and, the understanding of the district functionaries on the complexity of child marriage and the existing legal framework, their obligations, and yes, what all different sectors can and how they can contribute. We also set out to establish a district level interdepartmental coordination committee with the senior officials actually participating as a member of the committee and led by the district magistrate or even facilitated by the subdivisional magistrate, who is also, in some of the states and districts, the child marriage prohibition officer. We expected that this will lead to improved coordination, especially between the key line departments, education, health, and women and child, and the law enforcement agencies, the police and judiciary, with the local governance on effective implementation of the law.
Okay, you have 2 minutes.
Right, sorry, we're already. So this was the kind of model we were looking at. I'll quickly come to, what the support we had, because this was first time that we were doing it. There was no kind of a detailed guideline on it. So, but what we did, we took the directives and permissions from the nodal ministry. The communications were given to the state nodal department, and from that to district magistrate. What we had set out actually was looking for a district level plan of action with specific actions for the department and some monitoring indicators. Looking at the time period that we had, which was just 3 years, and almost 6 months goes into the planning and getting all the permissions and directives. We together with the districts in consultation, we identified a few actions that can be doable in this period. And looking at the scale at which the district works, was that key departments can try to integrate the issue of child marriage and a few actions within their existing framework, within their existing agenda. And one was to train and train the staff, and especially the frontline functionaries, on the subject, so that whatever work they are doing it, whatever agenda they are carrying out, they can also talk about child marriage, relate it to their work, and initiate community dialogues. This was also, it was required to provide a mentoring support to the, the large, huge human resource that we have in form of the frontline functionaries. And we said that maybe quarterly or minimum at least twice in a year, the committee should meet to review how the, the departments are working and what is the need and where we need to take it from there. Dr. Chandra, 1 more minute, please, 1 minute more. Huh? So evaluation, coming to Dr. Chandra's point, so an evaluation was done by WHO, and Susan was also one of the evaluator. Dr. Alka Barwa is not here. So the key question was about that, how Mamta contributed to the establishment of the concerted sectoral, intersectoral, district level efforts, and if it happened, how it led to more concerted actions at the block, panchayat, and village level, and what were the critical factors that contributed to these changes. So some of the findings are that the profile of child marriage was definitely, it was raised. There was a lot of support from the district leadership, which actually stimulated actions at the block level, and further it percolated down to the frontline functionaries, which led to the family and community mobilization work. There were tangible intersectoral convergence occurred at the village, level, but progressively less at each successively higher levels. So there was support, there was motivation, but in terms of having a proper mechanism, that was something, still wanting. Another thing that we came, was good in Rajasthan that we experienced that when Mamta was putting in these efforts, there were directives sent from the state government for the actions on child marriage. So when you carry out these efforts and there are directives from the national and the state level and there are repeated follow-ups, that actually helps in building up, the momentum for the action.
Thank you, Priyanka.
Dr. Chandra, just one last thing. Okay. So just one thing that I wanted to highlight from Dr. Chandra's evaluation was the great sectoral convergence which happened at the village level, and something that we have experienced through all, the people from the programming is that, the Panchayati Raj system, they did a survey for the 50% of blocks on the frontline functionaries and the Panchayati Raj members, and there are wonderful results. Almost 100% all frontline workers said that they believe that their approach to address child marriage underwent a sea change after their exposure. And this was only the training that was done by the departments, and that was also done only through integrating in their existing work. Thank you so much.
Please. Yeah. One of the things we didn't put in the report was one of the reasons for the success of this project was the doggedness of Priyanka Srinath, as you saw very clearly here. I'm going to ask Anju Malhotra to say what's her takeaway message.
Thank you, Chandra. I think this is a really great initiative for us to both celebrate some of the successes of intersectorality, but also to question a lot of the challenges. So the biggest achievement is sensitization of these departments, which I think we should think about whether we needed such an elaborate process to sensitize all this department if there was a more efficient mechanism for doing that. And then ultimately, did we take advantage of the unique strengths of each of those departments to address child marriage, or we have basically imposed awareness raising as the core mechanism, whereas health system should be delivering services to adolescent girls, education system should be delivering education to girls, so we're not changing any of the structural changes, which is why I do really question that everybody doing the same thing is not necessarily the best model for convergence, but everybody doing the thing that they know how to do best is perhaps a model for convergence that we need to consider.
Thank you, Anju. Thank you for challenging and questioning. Prabhu Das works for CARE in Bihar. Prabhu, you have 30 seconds. Your comment.
Thank you for giving me this opportunity, sir. I have remarks
25 seconds.
Yeah, I have remarks in two forms. One in the form of feedback, and another is in the form of an input. One is that, yes, I do agree. You have really immensely, appreciated the work that you have done in the 2 districts that you have done. My concern is when we do it at the district level. This is a question in the form of you being also, and sir is here. When we work with the support of NGOs at the district level or at the grassroots level or at the small pockets, we are very well doing it. But when we try to scale it up and when we try to do with the system's ownership, there are huge gaps. Can we have some inputs from your side for that? Second thing is...
No. Thank you.
Oh,
thank you very much. You can continue the discussion over lunch. Any quick reactions? Your question about the wider reflection we'll have in the second part of the session.
Yes, just a quick thing for ma'am, what you suggested was we were looking at the coverage because we have been talking about addressing the social norms and the gender norms, and we have a huge human resource through various departments, but nobody is actually acting on influencing social norms. So, the coverage, reaching out to the vast population through the existing human resource was important. That's why we thought of the training and, integrating these things as a first step. And yes, I understand the scale-up is very difficult, and Dr. Chandra always used to say that, it's the government who was supposed to do it, and as a programmer, it was very difficult to stop myself and say, no, now I have done my work at this step, and now from here further, I need to take a back seat and see how the system is going to work. It was difficult, but we tried our best to stop ourselves and give that space for the district to actually, but at times you have, these, the time period, the donor requirements that you just want to, hurry up the process. But yes, the district needs time to do its own processes. Thank you.
So 2 thoughts we'd like to take on. One is this the best use of the resources to bring about coordination? And how can we make sure that different departments make their complementary contributions, and it's not just all the departments doing more or less the same easy to do things? David Ross is next. He's going to speak to the WHO document Iaah and some examples of collaboration in that document. 5 minutes, David.
I'm going to speak very, very fast so that I get through my minutes. No. Okay. So I'm scared. Okay. So I want to just mention to you, if you haven't already come across it, you're the global Iaah. Please say it. Iaah. What's he talking about? Okay, I'll tell you very quickly. It's designed to provide guidance to support country implementation by governments, by NGOs, by all the various sectors. And I'm going to skip through, but just to highlight that this is a UN-wide document. It involves all the UNH6 partners who have been heavily involved right from the start in this process. And we're all now working in getting the document out to countries, workshops for them to really understand the document, led by my partner, Valentina Baltag in WHO. Not that kind of partner, my work partner. And just to mention, you can see here it's sections that run through the whole planning process for setting priorities in adolescent health programming based on the burden of disease, the risk factors in the local population, what is already being done, and what are known to be effective interventions. And then once you've decided what your priorities are, and what your interventions are going to be, how to get them into programs. And that's the part that I'm wanting to mention, just to highlight. To mention that it covers all the areas of adolescent health, plus, if you like, one which is often left out, which is positive adolescent development. Towards the end of the programming section of the document, there is a section which specifically provides guidance for 10 sectors: the health sector, education, social protection, telecommunications, legislation, roads and transportation, housing. You can read, yeah? We hope that we covered all the most important ones, but there's bound to be some that were not specifically mentioned, but in the text it's emphasized the importance of those. And so the key messages from the document include the fact that we must have adolescent health in all policies, as well as having particular policies and programs for adolescents. And that goes across all the sectors, but it also goes within each sector, that governments and civil society must review the policies for everything and think, how are these adolescent applicable and adolescent friendly? And I wanted to end by mentioning that within the document there are 75 country case studies. And one of them is for pregnancy prevention in England, where every local government area had a teenage pregnancy coordinator, because we had one of the highest teenage pregnancy rates in Europe. So the government decided we've got to do something about this. And that was controlled by a board which had health, education, social services, youth, housing, and relevant NGOs heavily involved in it. And that was mirrored at the national level. The funding for this and the mechanisms used were sustained for 15 years and then somewhat destroyed. But they were sustained for 15 years. And during that 15 years, the teenage pregnancy rate in England went down by 51%. One thing of personal experience, if I've got a minute left. So my daughter, when she was 15, developed severe mental health problem, anorexia, and was extremely ill. And at one time, she needed to go into hospital. And she was really frightened of that because she knew that they would force her to have nutrition. She was screaming and shouting, kicking, biting herself and us. So I called the ambulance because we just couldn't cope anymore. I'm sorry. 2 huge policemen arrived, one with tattoos all over his neck and down his arms. I thought, oh my God, they had flak jackets on. What the hell has happened here? You know, I've really blown it now. This guy with all the tattoos came in, saw my daughter crouched under the bath, biting herself, kicking herself, screaming, and went outside, made no judgments about the situation, and calmly said, the truth is, I cannot do anything here, but if you would like me to lie, I will say that I can. And so I said, sure, I give you permission to lie. He went in, he calmly told her, look, you made no judgment, no criticism, you're clearly distressed, you have to trust that this is in your best interest. If I have to come back, you'll get into a really bad situation, you know, with the police involved, all of those kind of things. That showed me that the training that I later found out that every police officer in our local area had had about mental health problems paid off. Our daughter is now at medical school, doing extremely well.
Thank you, David. Thank you for taking us from Iaah to the England Teenage Pregnancy Strategy and for sharing a personal example which clearly was distressing for you, but we are very pleased with the positive outcome. I'd like Sushma Dureja, who's working with Ajay Khera, to lead India's RKSK program, Deputy Commissioner in the Ministry of Health and Family Welfare, struggling with RKSK. What's your one takeaway message?
As far as the document is concerned, a brilliant document providing guidance to the countries how to implement the program. It's a broad-based document, and I've been fortunate enough to be a part of this writing group of this document, and it provides information on every aspect, how to implement the program. Of course, the country have to take their specific take on what all they need to implement. And as far as the convergence and the strategies concerned, we have to move ahead in a very definite direction. Thank you. Thank you.
Can you join me in giving David a big hand? We've looked at adolescent health programs in 3 different contexts. But we need to step out sometimes and learn wider lessons learned, not just in the adolescent field, but in the other areas of health and development. And Vani Sethi from UNICEF is going to come and talk to us about nutrition. I think I've got your name wrong. Yeah. Okay. We started 5 minutes late, and we're going to take another 5 minutes with Sunil Mehra's permission into the second half of the 45 minutes.
Can you stop using the mouse there, please? Thank you. Chandra, can I request you to calmly take your seat? Enjoy the presentation. I won't take much time. Thank you very much. I'm going to walk you through a few slides. Can I use this? Thank you. I'm going to walk you through a few slides of our journey of assisting different sectors to come together for adolescent undernutrition. My focus here would be adolescent girls because in this work, we largely focused on preventing the intergenerational cycle of undernutrition to impact stunting. That's what India's cohort is all about. In the 15 and 19, 54% anemic, 42% undernourished. Clearly, these women, and at least 50% of them, will give birth to small for gestational age children. Those kids coming to an Anganwadi center and then being fed good food supplements will later lead to obese kids and those with NCDs. Clearly, we need to focus on preconception and adolescence. It's common sense. When you look at the package of services for adolescent nutrition, if you see on the left-hand side, those are core nutrition, balanced energy protein, counseling on core diet, micronutrient supplementation such as WIFs, deworming, and also screening and management of at nutrition risk adolescents, which you in HIV call MARA, but even in nutrition we call this MARA. However, there's also something called nutrition sensitive sectors, which contribute to ensuring that the nutrients that go in stay in. And those are access to health services, safety nets so that we ensure that the girls are in school and hence they're not getting married and not getting pregnant. And also, those girls who are staying in infection-prone environments, such as those affected by fluorosis, malaria, are also getting treated and are being provided preventive measures for that so that you don't have infections led undernutrition. You also have sectors that are working on core issues of decision-making, voice, and freedom. However, they don't have nutrition goals integrated in their programs. And hence, what we learned was, as a part of our technical assistance to the Ministry of Women and Child Development in designing and supporting them in implementing the SABLA program, later the WIS program, and several other programs related to child marriage and others, what we learned that there are several sectors that are working and they need to converge to ensure that the girl is nourished. These sectors include health, social welfare, education, women's agencies and livelihood federations. You have opportunities under the ministries of tribal affairs, minorities, and urban, and there are different ways to work around these ministries. Traditionally, everything has remained under box 1 and 2, that is health and social welfare, but education, livelihood missions, and other sectors have a role to play. First, they do their job. The second is two sectors coming together. And how do they come together? Either one sector taps the other sector's platform. The second is they geographically converge so that you have two supervisors of two different programs that are working in two different areas. They actually converge their geographical sectors so that they can co-locate their services. They do budget pooling. And finally, these nutrition-sensitive sectors also integrate nutrition goals in their program because nutrition is too important to lie with just one ministry. And hence, I'll share with you two case studies quickly in the next 2 minutes on how education sector started integrating nutrition goals into their program and how women's agencies and livelihood missions were tapped to integrate nutrition goals in their programs. There are several case studies, but I'll take the case study of Purnia in Bihar. Purnia is one of the most distant districts in eastern India, one of the PM's focus districts because of its deprivations. And this is the situation of adolescent girls in 2016 in Purnia district. 42% stunted, 27% thin, 5% consuming IFA. Fortunately, 38% dewormed, only 2% accessing services, but 80% saying we are enrolled in school. This was the context. The first thing that we understood was that in a situation when weekly iron and folic acid supplementation is not working, and the Bihar government at that point in time felt, well, so the program should stop. As Mahatma Gandhi always says, that adversity provides opportunity. Should the program stop because there's no IFA tablet, or should we move on? So the Department of Education midday meal program brought together the State Health Society, UNICEF, agriculture universities, and the Krishi Vigyan Kendras that are there in the agriculture universities so that they can continue other aspects of the WIS program through the Ankuran program. The Ankuran program brought together agriculture universities for the first time, recognizing that they have an important role to play in schools, and the strategies were 9. That is, continue your biannual deworming, start nutrition morning assemblies in school, strengthen the screening of nutrition status under RKSK, which was largely missed, start school kitchen gardens so that kids learn dignity of labor and go back at home and start eating micronutrient-rich foods, start wash station in schools, start annual nutrition melas, where bring in the agriculture universities to improve the menu of the school, start PLA-based monthly sessions with the adolescents so that they learn life skills, and when the WIFS tablet comes, start giving it with DOT and monitoring it. In 1 year, we started very small because when you're moving with sensitive sectors, you have to also prototype that initiative before people believe it. Today, the program is in 100 schools. Bihar government has set up nutrition cells in agriculture universities as well as in the midday meal department, recognizing that education sector has a role to play in nutrition. My case study 2, the livelihood missions. India is known for women's agencies. Large women's groups are federated into village organizations who in turn are federated into cluster federations. They are running huge microcredit programs. Women are a part of it. Adolescents are not. Our take here was that livelihood missions have started with the Dashashutra strategy, that because they've recognized that in addition to 5 principles of credit loaning, it's not really leading to any change in the community. They need to integrate 5 other elements of social sector development in their programs. Using this as an opportunity, we tapped and started the Swabhiman demonstration program, designed, implemented, and funded by the livelihood missions through their own systems. This program is presently happening in 3 states, 4 districts, 5 resource blocks of Ajivika, that is India's largest poverty alleviation program, implemented, designed through 231 village organizations or over 4,000 self-help group networks. The target groups here are not adolescents alone, because this is one message which I would request to give is, when you're working with adolescents, don't segregate them. When you're working with women, don't segregate them. Work on the continuum of the care in a family-centered approach. If you look at the interventions are 5, sectors are 3, with each sector doing their own bit, rather than doing each other's job, but Ajivika providing the platform for doing something extra, or the scale gap which the health department can't do. Approaches are 2, system strengthening throughout the block, plus system strengthening and Jivika-led interventions in certain areas. What are the system strengthening interventions? I'll just take 30 minutes more. Thank you. The first thing is, we already have a village health and nutrition day. Can we just integrate adolescent health services in there? And hence, newlywed and adolescent girls were linked to the Arogya Divas in Bihar, because that's one day, same service provided to everyone. People can't keep coming again and again. Ajivika-led activities were those which the systems are not providing. And what are the things that they can do? Making adolescent clubs, using sports, entitlement camps, poultry-linked activities, homestead gardens, newlywed couple meetings, mobilizing for services. These are not done by any other sector. Importantly, no one does anything for free. Village organizations are given a cash grant by Ajivika to implement this program so that volunteerism doesn't die out. The poorest of the poor are providing certain services, and hence it should be costed. And hence, this is a community cash grant program run by Ajivika under the head of their vulnerability reduction fund called Soft Items as a nutrition investment fund for the future. We have a strong evaluation design to see what it works. And final slide is what mattered here and what is our lesson. Prototyping helps. When you're working with these sensitive sectors like education and livelihood missions, they want to see it to believe it. Nutrition is known to us, but is alien to them. They don't know how to do it. They want to see it and then move ahead with their own funds. Structures which help people together are important. Nutrition missions in the state bring people together to pool budgets. When we are integrating nutrition goals into other people's programs, you have to go by their philosophy and not your own philosophy. Their plans and not your own plans. Their thinking and not your own thinking. And finally, the feel-good factor matters. Each one of us sitting in this room, each government official wants to make a difference. Can we tap the good? Can we tap it in their philosophy for the scale gap and not duplicating each other's program? I invite you to come and see the program in Bihar. Thank you very much.
Thank you very much, and I'm terribly sorry to rush you and all the others, but we want to get through a very full agenda. Jane Ferguson was with Herb Friedman, one of the founders of the Adolescent Health Program in WHO, and I know for many, many years has talked about the central importance of addressing components together with nutrition at its core. Your quick reaction, Jane.
Brilliant presentation. Thank you very much. I just want to emphasize your last point about how people who are involved in this want to make a contribution and they want to see what their contribution is and have some kind of recompense, not necessarily money or incentives, as you said. And I think and you also said it at the beginning as well, the other thing is, do people know what they're doing, delivering what they're meant to be doing, and do they know then how that contribution adds, that it's an additive and make a win-win situation? Beautiful summary slide. Thank you very much.
One of my professors often told me, don't talk convergence, just do it. The second he said is that when you can't solve the problem with the same thinkers, bring more thinkers in the room. And the third thing which he taught me, and he continues to do today, is keep your ears and feet right on ground. These programs were designed by people most affected by deprivation. These programs were designed by people who have to implement them. And these programs were designed with an empathy approach. So oftentimes when we're talking about service providers, can you just run the film while I'm talking, just to save time? We think that appreciative inquiry should be used with communities, but we forget our service providers. They are humans too. They are facing problems too. So in this program, the two-pronged approach that was used is, ask an A&M what problem is she facing, so which is preventing her deliver her program, and help her with it. She's also human. My request here is all the people who are using PLA approaches with communities, adolescent groups, please don't miss your service providers. Why don't we also have PLA meetings with them? Because they need to deliver the services too. So I think a people-centric, empathy-based approach, believing in the local wisdom and the wisdom of each one of us matters. Everyone wants to contribute. Thank you.
Thank you very much. So in the first 45 minutes of this session, we've had presentations from Susan about Uganda. We've had a presentation from Priyanka about a child marriage program in 2 states of India, and David talking both about a global tool and the English experience, and finally from Vani about nutrition in India. We bring this particular part of the session to a close with a comment from you, Anju Malhotra.
Thanks, Chandra. It's so nice to be ending with Vani, and I admire her not only because she's from UNICEF, but also because the program she's highlighting is so solid and so good. And I think the one key takeaway message from what she has highlighted, and I was talking to Sushma Jureja also, how much I admire the WIFS program in particular, is the ability to take to scale by focusing on serious service provision and being really, really focused on your result. You can do one single intervention instead of doing 12, but if you do it well, you can tap the strength of every single sector. And I think the most important thing Vani said is that when we're working in disadvantaged communities and low-income settings, you cannot underestimate the importance of service delivery. You can talk norm change all you want, but the biggest favor you can do people is actually provide them good quality services. I think David's point about what he said about his daughter, which was so touching, it made me think, yes, the training had not been failed, but if that had happened in this country, in a disadvantaged community, there would have been no ambulance, there would have been no hospital to go to. And that service provider, yes, would not have been trained, and all the norm change would not have helped you because you don't have the basic essential services.
Thanks, Chandra, and thank you everyone for wonderful contributions and case studies that we had. Let me very quickly move on and keeping the energy of Chandra intact to get the next panelists on the table very quickly. May I request Dwarka, can you join us from the UNICEF? I'll give opportunity to people when they talk to give a one-line introduction about themselves. Anika, Dr. Anika from the UNFPA. May we have Rebecca Lundgren from University of Georgetown. And may I ask our two state representatives who have very quickly agreed only yesterday to be part of this, Dr. Hariom Dixit and Dr. Vinod Pathak. And then lastly, a colleague from the Sweden, Dr. Devika Mehra, to come on the table, please, on the dais, please. Thank you. Just without giving my own thoughts on these issues, I will straight away go to the panelists. I have strong views on it. I'll just reserve them for the end. And let me begin. The way we are going to plan this is that I'm going to pose a question to all of them, and I would request each one of them to give that answer in 2 minutes. And let's keep this to 2 minutes, please, so that we can open it for discussion. Before I start, any particular thought from Dr. Khera? How would you like us to? Okay, thank you. So let me begin in that order. Dwarka, I know you work on child protection issues. Would you like to share some of the learnings that you have had, and what would you like to suggest in the end, 1 or 2 key steps that we must keep in mind for addressing the convergence issues?
Good morning, everyone. I'm Dwarka Sriram. I'm working with the Child Protection Section in UNICEF India, but I also wear another hat of managing the adolescent programming for the country office as well. So I think after coming to India, some things that have kept me awake at night, but also challenged me, is about this convergence. Because the fact is, personally, I'm just tired of meeting so many people and also having conversations every day to talk about it, but not doing anything about it. So I just wanted to give a quick overview of, having seen some of the programmings in the districts and blocks as well as at state level, what we would need is to have one common narrative and a common vision for coordinated results. Because all our investments with and for adolescents need to be greater than, sector-specific interventions. So how do we go about doing that? The second is, how are we going to be leveraging programs of the government? Because having said, we have implementations with NGOs, we are doing our own programming. But at the end of the day, when you want to scale up results, which is the other question that keeps me up at night, and to do it sustainably, what are the programs that we really need to converge? And I have to agree with Anju on this. How do we do this better? And Vani, I had elaborated about some of the possibilities of how to do that. And finally, we need to work with and for adolescents using the asset-based programming. So how do we look at that? The second point of mine is about convergence at various levels, of administrative levels of India. I mean, India is so diverse, with some of the states being the size of Nigeria and Brazil. So how do we really look at convergence at various levels, national, state, district, and sub-district levels? And then finally, I think the convergence of the government and civil society organizations, the interface that happens there, as well as with other key influences that we have, such as the private sector, the media, the parliamentarians. So these are some things that we also need to look at broadly when we talk about convergence. It's not about just government converging together, but also looking at other key actors and players sometimes we may not tap into. And I like Vani's last sentence about getting other thinkers on board as well. I think some of the challenges I would like to highlight, and then I'll just go into very quick opportunities. Most of the programs are very much scheme-driven. If you have a problem, come up with a scheme, and most of them are sector-specific as well. The second is that most of them are for girls, and there's no accountability mechanisms or convergence mechanisms as well, because each of them are led by a particular line ministry. There are also no accountability mechanisms linked to governance structures as well. And capacity building, both human resources as well as skills, especially if you look at child protection, we do not have a ground force for us. But also the motivation. What is it that will make that difference for them to bring about convergence at the levels? Finally, linked to implementation is that we have to reach millions. We have to ensure the quality, whether we do our own programming or through the government. And we have to look at monitoring mechanisms to show measurable results. With the civil society organizations, again, most of them are very much vertical, so there's no expertise in other areas. But also, most of them are donor-driven. The expectations of the donors are immense, and I would recommend some of you to read the study that was done by Shireen Jijiboy about supporting transitions, which really highlighted some of the key aspects, especially for donors to keep in mind. Linked to that is the limited funding that we have, also annual funding that we keep getting as programmers. And sustainability and scalability of the NGO-driven sometimes programs, but also of the government as well. When the governments change, they come up with new schemes and new programs. And finally, for civil societies, the interface with the government, because again and again, I see very siloed approach. How do we get together? Just in terms of quickly opportunities, I think the political commitment and the leadership are there. The planning processes, we need to have that common narrative across the different key actors. We need to look at mutual accountability as well. I think accountability is critical for our programming on the ground. Mapping of these existing programs. In Maharashtra, we have 1,700 schemes for adolescents and children. How do we really look at the budgetary analysis, looking at coverage, access, implementation issues as well to bring it together? I think other key component is documentation, process documentation, but also evaluation. But one thing to keep in mind is sometimes this copy-paste approach also doesn't work. What happens in one state may not necessarily work in another state. Decentralization is key for us. Even yesterday's session we had on child marriage highlighted it. How decentralization with funding is helping convergence at various levels as well. We need to one more point. One is institutionalizing the capacity building, and I think this is very important for us because we need to look at the motivation and the skills apart from the workforce that we have on the ground. Thank you.
Thank you. Apologies for Anika.
So if we start that clock there, we can keep, if you start the clock. Can someone start the clock?
No.
It's easier to keep track and plan what you want to say.
Okay,
so
I'll try that.
Thank you. I'm Annika Knutsson. I'm the chief of the Sexual and Reproductive Health branch in the technical division of UNFPA. I'm a midwife, which is important in this area of convergence because I think midwifery is a very convergent sort of profession. And I have been with UNFPA just since January. Before that, I had the donor hat on. Now, I just want to say, and I don't want to repeat what others have said, but some things that I think are important for us just to be aware of in terms of challenges, I think is something in our human nature, which is very important to remember. I think that we all want to participate, we all want to contribute, but we also all want to have our own stamp on what we see is the result or what is the change. And I think that unnecessary possessiveness, lack of trust to others, and lack of communication are very important things when we think about how can we overcome the obstacles. I think that we need to make our partners aware of the interlinkages and the evidence is there and understand the importance of the other. Then I think we have better trust. If I take one example from the child marriage program, which I think is a good example of making use of existing mechanisms, because that has been mentioned and I think that's very important, is in Niger, where the Ministry of, it's called Ministry of Population, Women's Empowerment, Child Services, which in itself is a multi-sectoral ministry, took the lead. And very successfully so, because I think they understood what it took to get the different parts together. I also think that it's about bureaucracy and it's about how we are set up, but it's mostly about communication. So I'll move to the opportunities. And I think the SDGs is a very good opportunity because it will force us to work together. We need to have the multi-sectoral approach if we're going to succeed and achieve them. Decentralization has been mentioned because I think at the lower level there is less division for obvious reasons. I I do not think that we should ask health providers to be too much multitasking. That's not how you get about it. It's not, but as others have said, have a platform. Now it's blinking, my God. The clock is blinking. Anyway, but the most important, we need to put the adolescent in the center. And if we all have that perspective, it's easier to assemble around it. And let me quote Kate Gilmore from another session this morning, where she said we need to humanize the adolescent journey. And what she also said is that we need to leave the fictional comfort zone. So if we use the mechanisms that are there, and we have shared priorities, and we create some regularity in communication, I think we're very much on the way.
Thank you.
Hi, everyone. My name is Rebecca Lundgren. I'm from the Institute for Reproductive Health at Georgetown University. I want to share, in kind of the spirit of doing, like moving into doing, my perspective from like what I do to support convergence. And so my hat is I'm a researcher and I'm also a social anthropologist. So that's kind of what I bring to my work. I was part of the GREAT project, so I'll think about that a little bit. So, you know, I really see my role as I kind of come in. I think there are a few of us in this audience who wear similar hats. So when I'm going into a system, you know, we anthropologists are known for systems thinking, so I really take it upon myself to think about what is the broader system here, whether we're planning a research, a pilot project, you know, designing something, see what the system is, make sure we bring together the right people in the room. The example Susan gave of GREAT had linked outcomes. It was violence, family planning use among adolescents, you know, using gender and also addressing gender. So it was clear that we had to have, you know, more than the Ministry of Health in the room. We had to have the Ministry of Education, the Ministry of Gender, and others who were all going to play their part. So part of that role is working with those stakeholders to really think about what is our program theory of change. You know, what are we trying to achieve? What roles are different people playing, different organizations, different structures, so they do get their credit and their voices heard. And then, even more importantly, like what are our outcomes? So how can I expect, you know, other systems to be, or sectors to be interested if all we're measuring is family planning use? We had a lot of pushback because we weren't measuring school retention. We were measuring certain indicators that other sectors were interested in, even though we might have been developing them. So think about indicators that people can own. Think about people's individual or institutions' individual motivation. Why am I in this? How is this going to help me achieve that? And even more so in research, you know, what is the evidence that will be credible? What do they want to learn? What do they want to know? Do they want stories? Do they want service statistics? Do they want RCT results? So really bringing those voices in as we're trying to design for convergence. Also thinking about monitoring. So what is the monitoring data? How do we involve and engage the different sectors in that process? So for example, in GREAT, we made sure that we had site visits with different sectors, not just the Ministry of Health, but others, doing the monitoring, but also interpreting the data, applying them to the program to make sure we can improve the program over time. Scanning the environment over time, applying that kind of systems approach. You know, elections are coming up. You know, Ministry of Health folks are going to change. You know, can the schools take on more of a role? You know, so really kind of keeping that systems lens in mind. I guess one last thing, you know, the systems are critical, and those are many people here speak to those better than I do. Susan mentioned the DOP process, but that didn't work in every district. It didn't work because of lack of leadership, lack of capacity building. And I'll leave with this one example. We had NGOs coming together in the scale-up phase, and the district coordinator was meeting with them and coordinating, and they have a meeting, and they're all sitting there, and he says, okay, let's plan, let's talk, and they're kind of sitting there, and he says, you know, I want you all to take notes. And they weren't built, the capacity of those individuals weren't built on how to work with the ministry. You know, and he said, do you need pens? Do you need paper? So really helping to build capacity, as several of my colleagues have said, so that you can, capacity in communication, cross-organizational communication and understanding, so that you can have those soft skills to promote convergence.
For Shift, I'm just going to move to the practitioners who are actually going through this intersectoral convergence at state level. I'll take one by one. Dr. Pathak, would you like to start?
Yes, thank you. Thank you, sir.
Try
Dr. Vayan Pathak is my name, and I am a state program officer working at Bihar and stationed in Patna. Patna is the headquarters of the state of Bihar. And I'm looking after this RKSK program in Bihar. I'm very fortunate, this is my privilege that my champion, Madam Dureja is here, and the champion, Dr. Kheda Sahab is here. They have guided us to how to navigate this program in your state, because this is a huge country and very diversified country. In Bihar, we have 38 districts, and we have this challenge that we have trained the 40,000 teachers for this WIFS supplementation program and 85,000 ANMs. And because of this convergence, you have just at the state level, at the district level, at the block level, you try to manage a very good convergence with the line departments, with the education department, with the social welfare departments, and with the women and child department. At the state level, we have a regular meeting at least twice in a year at the principal secretary level or the secretary level. Then we have a district level convergence meeting at the district level with the chairmanship of the district magistrate of the respective districts. Of course, it's a very difficult task, really practically very difficult, to make every officer on a one platform and discuss about the RKSK program or the WISP program or the menstrual hygiene schemes. But because of the proper navigation at the district level and discussion with the chief medical officer or the civil surgeons, you are trying to make a very good convergence with the other departments at the district level. You have tried to make them trained to how to operate this WISP program in your districts. But the important thing is the action. It's very difficult to collect all the senior officials at the district at one platform. Same thing, it's very difficult to bring all the district block level official, PSC block level official, whether the medical officer in charge or the CDPOs or the block education officer. They will come together and they will send a message to their teachers or the respective Anganwadi workers to look, this is the program, and they have taught them in their local dialects how to deal with this program. We have a very good training because of this convergence. We have 1,20,000 teachers and Anganwadi workers. We have trained them in almost a six months program. It's a very huge cascading model of training, but very useful. Unfortunately, due to some convergence between the health, our department and my sister department, that is Bihar Medical Services Infrastructure Corporation, who is the lead agency to procure the IFA tablets and procure the albendazole tablets. But unfortunately, from last 3 years, we are trying our best. Our secretary is trying our best. Even the government of India is pushing them to just procure the 100 crores of IFA tablets, a very huge, large number of IFA tablets. But somehow, it will not happen. But the good news is that within last month they have decided the rate has been decided, and hopefully by the end of November or the beginning of December, we'll able to procure the IFA tablet, and we will distribute them among the children, 2.23 crores children in our state, to whom you try to supplement the IFA tablets, a very large and huge supplementation. And I think this is one of the biggest supplementation in the state of Bihar as far as the IFA program is concerned. But our manpower is so important and they are so dedicated. Once the tablet will come, and we'll try to put them in the schools and the Anganwadi Kendra. And weekly, we have a system with the UNICEF people. Vani, where she is? Yeah, we have a very good system, and we have developed a very good online system to report back the ascending order weekly about the IFA tablet, about the albendazole, how much they have used, and what is the percentage of supplementation. So this kind of mechanism we have developed, and it is a very very good thing to see how the Bihar is going in for the next 6 months. Thank you very much, sir.
Thank you so much. Sorry. It's a great time for me to shift to a council project of Sweden, which I have learned a lot from, and try and bring it back, how their county council brings this integration happen, taking on from what you're saying, what has happened. I have a young person from there.
I'm talking for Sweden and Annika is here. I don't know. Okay. Yeah, I'm a PhD in sexual and reproductive health and rights from Sweden, and I've spent 8 years there. I'm talking in that capacity of having grown up in India and seeing the differences and how beautifully they converge within their systems, starting from school level of having a counselor to the nurse within the schools. And I know it's comparing apples and oranges, but still small examples where I think we can take learnings from Sweden is like, seeing RKSK has come into play and now we're trying to scale it up. That in the 8th standard, they are taking to these youth-friendly health clinics. I think those small visits can happen where they are taken to these AFHS centers where they know where to go rather than them having these problems and challenges of access of services. That is, I think, one small example where I feel we could doable things. And then it's one of the first countries which has sexual and reproductive health rights policies come into being. And I think data is a big problem in India, and they are doing very well on that. They have very good data for monitoring, and they have been doing, I mean, India is still grappling with sexuality education. They are very, very far ahead. But I think if we have good data, it will be very easy for us to tap how we are, where we are in terms of implementing and monitoring things. They are doing this national survey now, which I was just reading yesterday, from 16 to 19. They'll be having an SRHR survey at a national level, which is going to help them for further planning. And I was thinking in terms of gender. It is a country which is really rights-based, having a rights-based approach. Gender, we keep talking gender in India, but they really take it very, very seriously. And talking about paternal leave and your maternal leave, which is really fascinating, having 1 year paid maternal leave for a mother and 6 months for the father, which he has to take, and if he doesn't take, his salary starts getting cut, which I think is something we can learn from, but I think India is still far from it, because in terms of how our economy works, the government is trying to get somewhere. I mean, I was talking to the colleague, Jane. She was saying in the US, we just get 3 days, and that's about it. But I think we should start addressing challenges of how women are facing, because India is a growing economy. Women are going to the work front. If we try starting supporting them at these levels, it will really make a huge change. And so bottom line, intersectoral convergence is great, and they also have challenges. They also have similar processes of, we're talking about decentralization. They are doing similar things. They are facing their own challenges also. It's not to say they again have their own, some municipalities are doing better on certain things, some municipalities are not doing great. They have their challenges, they talk, they interact, and things are progressing. So it's something to learn from, and I'm happy that I live.
So let me very quickly take to Dr. Hari Om Dikshit from Lucknow. And I think it'll be good to have his thoughts on how UP struggles or able to succeed. I think it will not be a bad idea to talk about struggles. Yes, there would be success stories, but I think it's good to tell what do you think are the struggles which we need to look at.
Dear friend, we all are discussing convergence for last 1.5 hours. 38 years of my experience in the government services, working in the primary health center, community health center, district level and state level. At present, I am working in the National Health Mission. If your approach is democratic and you work as a team, and if your belief is that cooperation is always given, not taken, then it gives a better environment, convergence environment with the other department. Friends, if the cooperation is always given, you create a better environment with other departments. They have got different priorities. You want cooperation. It's difficult for them also. The best way is you just cooperate. Try to converge with them, and whenever there is opportunities, I used to cooperate. I used to go in the meeting of the state level, their departmental officials. I used to discuss with my program as per the guidelines of the government of India, and the strength of my state and the weaknesses of my state. I am quite successful, and most of the time I am 70 to 80% success. 20 to 30% if I fail, it is because of multi-sector problems in my biggest state of India. Thank you very much.
Thanks. we can have some thoughts briefly or questions to anyone that you have, but we'll have just 3 questions, please, right? I'll just leave it to audience. I won't go the Chandra route. I'll just keep it open, right? I'll just get to you first, please. Yes? Can you give the mic, please?
Thank you, sir. I'm Nitin. I'm representing the Uttarakhand team. My just question is like, we had very good learnings from Bihar. So the idea was like we have a WIFS program in place. So because I think engaging the agriculture university was a great convergent approach. So is there anything on the food fortification? Something we have some program where iron fortification is also being thought of in Bihar, and if there are any results on that.
Would you like to answer on food fortification?
Because that can be like, because we have the supply problem for WIFs that you had said for the iron IFA. So probably an approach of that line has been tried in Bihar, or if it is there.
Right now, we are not in a position to fortification, but since our first priority is to supply and administration the IFA tablet, IFA blue tablet to our population of adolescents, boys and girls. But certainly, in future, we have a discussion with the UNICEF and the nutrition department, and we will try to make a fortification with for this program.
I think the question that comes from you is, how do we see 2 departments working together, where one side is folic acid and IFA, who have challenge of procurements is a huge issue. How do we complement it by the food fortification simultaneously, so that we are not missing the link? I think that's what your question is.
That's right, sir.
Can we get to the next question, please? Yeah.
This is not a question actually about regarding convergence. I am from Odisha. About these residential schools programs, screening of the children. Initially we started in Odisha, there are SC/ST ANMs are available, but there was no convergence with the health department. Now we started the training of these ANMs, then school teachers, and with RBSK team, we have started this convergence program, and we are finding it is a very useful one, and we are getting data. We are generating these programs, implementation of different programs, and also creating awareness in these
Thank you. Thank
schools.
you very much. Anybody else? Yeah, please.
Thank you for the opportunity. I'm Rasmi Mohanty from IntraHealth International. And as a country, we have started AAA approach, which we really did not discuss much in this forum. ASA, Anganwadi worker, and ANM. And in many parts of the country, they are really doing a great job, and how we can think of their career path, and they can weave in this adolescent component. And another aspect we talked about is how we can think of monitoring, because in India, we have a department which looks after all convergence, like I think Ministry of Empowerment or Women and Child Development. I may be wrong, but how we can really bring everything, and as Dr. Khera mentioned, how we can look into monitoring of how every department is working together may further strengthen our convergence efforts.
Thank you. Thank you. Can this be, just last question, Hema? That would be the last one. Can you give it? Okay, that's okay.
I'm Dr. Rakesh Vedya from Gujarat. In Gujarat, the conversion strengthened, rather I can say, since 2002. Sabka Saath, Sabka Vikas. The then CM is now PM at the village level in the Gram Sabha. So their convergence worked very nicely. And the convergence at the village level, taluka level, district level, and the state level is a crucial, important point. Thank you, sir.
Sir, I just want to because I work for the government, I work as an individual level and also through our association. So with experience of 15 to 20 years in this field, I feel that everybody wants to contribute. We can see that. There is a lot of enthusiasm. We all want to contribute in some way. But I strongly suggest that maybe our clinic should be more youth-friendly, wherever they are being located, to look at other models. And then we get in the youth-friendly concept, and the convergence we really should not talk, we should start doing it. And we should have maybe at the national and state level some commissions where we have different partners, not just the health sector and other sectors which are too health-centric. We can get in other players on board and have a commission at the national level and also at the state levels. We have clear mandate for India, which will be a more successful model maybe. So this is a suggestion.
Thank you.
And thank you.
Thank you. Just in the end, before I pass it on to the chairs, I think I've just two thoughts. Whatever has come out of this meeting or the sharing of thoughts, there's one thing: we need an environment of convergence. That environment of convergence is critical for convergence, and this means that policy and programmatic directives have to be very clear about the elements of convergence. Two, I like what Dr. Hariham Dixit said, that there is an intent of mutual giving and taking, understanding the constraint on both sides, which means we don't lose track of the outcomes and indicators that we need to achieve. Lastly, what I would say is, from my child marriage intervention project on intersectoral, which Priyanka presented, I think there was a good leadership need as a decentralized needing at the district level. Even if you have directives, even if you have program directive, if the leadership at the district level does not facilitate the convergence and does not monitor and a clear indicators given to each line department for a common outcome, that if I'm going to report on education, school retention, I'm going to report on my livelihood linkages data, I need to report on my nutrition coverage, because all of them ultimately will lead to adolescent health outcomes. So we need to be clear in each line department that what are the 2 indicators, 1 indicators, 3 indicators we are reporting on within our work framework. It's not to say you're going to do anything extra. Within your work framework, what are the 2 indicators that you think you're going to report on as we move further in terms of the outcome of a particular adolescent health? I pass it on to Dr. Khera for his input, and then to Anju.
No, thank you very much. I think it has been an excellent discourse on the issue of convergence, which we are talking about it. I think very interesting experiences. I mean, just as a take-home message, which I am taking this from this particular session, there are 4 critical messages. Number 1, the convergence doesn't have to be a forced convergence. It has to be a felt need. It has to be a sustained convergence. Because what I am finding across the country is, we talk about convergence like a forced activity. So it should not, be forced upon. And another important point which we must take into consideration is, it should be the felt need of the different departments, different organizations. I think Dr. Hariom Dixit raised that point, cooperation. But whenever we should talk about convergence, we must invest time, energy, and even we must do some kind of advocacy. Why we want convergence? Sometimes we don't spend time and energy in terms of convincing each other. We just start convergence. So I think advocacy for getting convergence implemented is also one of the critical parts. That was number 1 take-home message. And then the take-home message 2 is, everybody is convinced, yes, convergence has to happen, but I think unless there is a leader in the group, things won't happen. I think that point also came up beautifully in one of the presentations. I think leadership, somebody has to lead it, and it can be led by health, it can be led by women and child, and depending on the subject matter, it could be, like child marriage, or it could be the drug abuse. And, one can pick up, I think leaders have to be identified. It doesn't have to be health ministry always. So I think selection of a leader is also very, very critical, because sometimes you force upon that only health ministry will do, but then, things won't go long. The second important point. And the third is, because convergence is not an automatic process. Investment has to happen, and investment in terms of capacity building. And I think, again, example of Mamta, where they did a lot of kind of investment in terms of capacity building of the people. So complete, the whole structure, which is implementing the whole mechanism of convergence, there has to be investment in terms of capacity building. And the last but not the least, like for any project, like for any, kind of intervention, I think convergence is an intervention in itself, and it has to be monitored well. Our targets have to be very, very clear. Where do we want to go? Like early marriage, I want to reduce. I means we all want to reduce early marriages. So we should have a very clear goals, and obviously if the goals are clear, we should have indicators, whether in terms of outcome, whether in terms of process indicators, and I think they should all be, we should be able to sit together as a team and prepare those indicators. So these are the 4 important messages, and I think investment has to happen in this area. Thank you very much.
Thank you, Sunil. I'll try to be brief. I think that there's one thing that everybody has said that we should take away. Do not do convergence for the sake of convergence. Convergence is not a goal. It's a means to an end. What's the end you want to achieve? That's the most important thing. Secondly, having worked in the field of gender and adolescent health, my 2 passions all my life, I have seen that because they are so intersectoral and they require so many actors to achieve, these are 2 areas in which it's very easy to do superficial convergence. It's very easy to say we'll integrate gender into this sector or we'll integrate adolescent health into that sector and then just pay lip service to it. And therefore, it's really important to do convergence meaningfully. What I loved about the comments coming from the people who really have experience from the field, that convergence is about cooperation. Ultimately, that's what it's all about. Convergence is about giving respect to others and tapping their expertise and their infrastructure, and also bringing something to the table. And the best way you can do that is let the people who know how to do something, let the health people do health work, but ask them to change something a little bit or add something a little bit that they can take to scale. Asking schools to have an assembly on nutrition is not a big ask. Asking a school to have an entire health infrastructure is a very big thing to ask. And so let the schools do what it's possible for them to do with their resources. You can go a long way. It's especially important not to overload service delivery systems in poor settings. If you keep asking for the earth, moon, and sky from a poorly resourced, poor capacity service delivery system, you'll break that service delivery system. So you need to ask what's feasible. And finally, I wanted to just, I've been saying this since yesterday, the tension between social norms and service delivery. We talk a lot when we talk about child marriage and adolescent health. Certainly there are a lot of social norms to address, and we do need to address attitudinal change and behavioral change. But let's not forget service delivery. It's at least equally important, and frankly, having done so many social norm change programs in South Asia myself and having believed in them strongly, I feel it's very unethical to have young people think differently and want differently and not be able to really support their need to meet those needs. Thank you.
Thank you so much. Let me end this session with thanking the chairs. Thank you, Dr. Khera. Thank you, Dr. Malhotra. And thank you, everybody on the panel. I'm sorry if I just pushed these things. This was for the purpose of timing. Thank you very much. Thank you all. And thank you, Chandramouli. Thank you so much for carrying the agenda forward. Thank you, everybody, for joining us. Thank you.